Ashish?
Yeah,
Okay. So we
please.
have Dr. Nalini from Aurangabad, I think, who's going to present the case. Dr. Nalini, your camera is, it's on?
Yes, ma'am.
Okay, okay. Hi.
So a very warm welcome, good evening, and I welcome you all on behalf of IPS West Zone PG Psychiatry Education Committee to our Tenacious Tuesday Teachings program today, third series edition 7. The topic of today's program will be discussion will be psychiatric emergencies. We'll have a case presentation and flow of the program will be I'll be introducing our esteemed experts. After that we'll go on to the case presentation. Nalini will present the case, then both the experts can ask her questions or add on to if add on to anything they want to. Then we'll also be asking the audience to type any queries or questions if they have in the chat box. We'll be taking those questions, and after that we'll have a 10-minute quiz session. Dr. Bhushan sir will be taking that, so we have that also. That will be the flow of the session. So introducing the topic, today's topic is psychiatric emergencies. So as such, there are not many emergencies in psychiatry, but the few which there are, we need to like really put emphasis on it, and it is an important topic for all residents and all psychiatrists. So it's an important topic, and both the experts are like very senior and pioneers in the field of psychiatry. I'm very honored to be introducing them, and I hope we all get to learn something from the session. I would like to introduce Dr. Shubhangi Parkar ma'am, who is Dean and Professor at Vedanta Institute of Medical Sciences, Palghar, Maharashtra right now. She has also been Dean at St. GS Medical College and KM Hospital formerly, and she has done her DPM, MD, MSc, PhD, PGDHR, and she also has many awards and felicitations under her name. It was difficult for me to fit everything in 2-3 slides. She has worked as an ex-convener at the MCI Nodal Center at KM Hospital. She coordinated basic and advanced course which were coordinated by MCI. She was also a member of the medical education unit in St. GS Medical College and KEM Hospital, Bombay. She was a resource person for the basic course and advanced course of MCI. She was also a resource person for FEMER. She has been teaching since the year 1986, so she was a huge experience in teaching. Uh, she has been awarded many awards for her papers and for her papers, which includes BC Marfati IPS Best Paper Award thrice. Then she was awarded 5 times AV Shah Award, 6 times she has gotten the LP Shah Award, and she has also has 2 time national awards for best publication. She introduced a new method which is called the socio-cultural autopsy studies of explaining suicide based on cultural epidemiology. She has also co-authored in a book of suicide Indian perspectives. We can find it online. So ma'am is like, she is a big name, and she is an expert in this topic, suicide as well. Um,
I just wanted to add, Saranda, if
yes,
you
ma'am. Yes,
allow
ma'am.
me.
Yes, ma'am.
Ma'am has been my teacher.
Oh,
I have seen her entire HOD tenure because I have spent more than 30 years in the Department of Psychiatry, and out of that, she was the teacher and then the HOD. She was my PG teacher as well, and been an examiner umpteen number of times. So I think the best expert to have for our PGs, and they can learn from her. So I
yes.
welcome ma'am, and I also okay, you introduced, but I also welcome Dr. Ashish. Good to have you here. He has also been a teacher for many years, and we hope that our PGs will learn from both of them.
Yes, ma'am. Parker ma'am had come to
આજે
our
માઇક
institute
કોણ
also
બોલે છે
as an examiner. Uh, for my junior batch, she had come as an examiner, so I have seen her. And now introducing Dr. Ashish sir, I in the last TTT session where I was the moderator, sir had conducted the quiz, so I have spoken to him before also, and he's made it very easy for me to speak to him, and I'm like very happy to be working with sir again. He's MD Psychiatry, and he did his MD from Institute of Psychiatry and Human Behavior, Goa University in the year 2006. Currently, he is working as assistant professor in the same institute, and holds a long history. Like since 2006, he has been teaching, and he has also been assistant professor in Manipal, Kasturba Medical College, Manipal. He held the position of honorary president of Goa Psychiatric Society in the year 2018 and 20.
ઓય,
Same tenure, he was also secretary of IPS West Zone branch. He has been a past executive committee member of IMA Goa and assistant editor of Annals of Indian Psychiatric Journal. And right now, he's the chairperson of our quiz committee, IPS West Zone uh, quiz committee. He has around 20 research papers under his name in indexed peer-reviewed national and international journals. He has authored a chapter called Psychiatric Training at Undergraduate Level for a book on mental health under Directorate of General Health of Health Services. So he is an expert for UG psychiatric training. He has trained many people, like he has an experience of teaching many students of not just psychiatry but undergraduate MBBS students, MPhil students, psychology students as well. And he also wrote a chapter on OCD. He received the Young Psychiatrist Award in
તો
2008.
નહીં.
So,
Go ahead.
so that's it. So I am very happy to introduce both of you, and it has been a pleasure interacting with the two of you. And
Yeah. At the outset, I'll say a word. I think I am still learning, Madam Shubhangi. When you were teaching, I was not even a student. So I'll continue to be your student and let's take it on that way. Yeah.
thank you, sir. Ma'am, Shubhangi, ma'am, would you like to say something? Ma'am, you'll have to unmute. Ma'am, you'll have to unmute. We can't hear you. Ma'am, we can't hear you. I'm so sorry. You'll have to unmute.
Good.
Yes, yes. Now we can. Sorry.
Okay.
Yes, ma'am.
Well, good evening, everybody. I think it's very nice to be with student. I still continue with my students. Some of them have joined today, and of course, I am in a very different background. I come from a very well-established institute. Now I am in the developing institute. Great experience, and I think today I'm not very sure. Psychiatric emergency, which case is being going to be presented, but I think psychiatric emergencies have been challenging, and I won't say there are not many, Saranda. I mean, in KM, my students remain on call. I also, when I was in Sion, I almost sat in the casualty to see the cases because the Sion hospital was amongst the Dharavi. It's one of the biggest slum establishment in the world, and there were too many cases, and that time the residents were very restricted, very limited. So we used to really sit in casualty and used to see delirium, suicide, psychosis, possession syndrome, so many. I mean, the suicide and especially alcohol withdrawal, drug withdrawal. So I think it's a challenge for our students, and it's a lot of work. It's a huge work. if you are in the medical college and also in the private practice. So this is a nice topic, in fact, for all of us to learn. There will be experiences of the students, and it's great. It's really nice to be here. Yes.
Thank you, ma'am. Thank you for correcting me. Thank you so much. Shall we start with the presentation, ma'am? Shubham?
Yeah, I think we can, ma'am.
Yes.
Dr. Ashish. Yeah.
I would like to introduce our speaker, Dr. Nalini, who is a third year resident and she's from MGM Medical College, Aurangabad. I'm very thankful for her to have volunteered to present this case of suicide, and also I would like to thank Dr. Manik Dise, who pushed her to do this and supported her and encouraged her to do this. Nalini, I'll be changing the slides on your behalf. Are the slides visible?
Ma'am, can you just minimize the slides a bit?
Okay. I don't know how to do that. योगेंद्र भाई मिनिमाइज कैसे करें?
Or shall I share the screen?
Whatever you are
That will be
comfortable.
better if you can
Yeah,
share
yeah.
your.
Yeah, you can share your screen,
Yeah, yeah. Whatever
Nalini.
you feel comfortable.
Yes, ma'am.
I'll stop sharing. I would also like to ask the participant students, meanwhile, that you can write in the chat box whatever psychiatric emergencies you've experienced and whatever you've learned from psychiatric. What all emergencies have you seen in psychiatry in the casualty? What all cases you've seen? You can write, mention there.
Ma'am, is my screen visible?
Yes, it is. It is. You can start your slide share.
Is it visible now?
It is visible, Nalini. Niche there in the bottom, in the footer, there is this slide share option. No, you just click.
Yeah, yeah.
Yeah. No, the right one. Yes, yes.
And slide shuffle, yes.
Yeah.
So shall I start?
Yes, yes. Shall we start, ma'am? Parker, ma'am, sir.
Please go ahead, Nalini.
Okay, okay.
So today I'll be presenting a case of a patient, Madhav Digambar Ardad, a 21-year-old unmarried male belonging to middle class, Hindu by religion, was pursuing a hotel management course and a resident of Rampuri, Taluka Gevrai from Bid in Maharashtra. The identification marks, he was a right-handed person with the following identification marks: a mole of 1/2 mm of brownish black color on the ventral aspect of the left forearm, 1 centimeter below the cubital fossa, and a mole of 1/2 mm blackish in color on the chin, 2 millimeters below the lower lip. The date of first contact with the health establishment was in 2023, which is not traceable. He was admitted from the OPD routinely at 2 p.m. on 26th of March 2024. He was accompanied by his father, Mr. Digambar Ardad, and the information given by him was reliable. The other informants were Mrs. Mukta Ardad, a 45-year-old female, mother of the patient, and Miss Jnaneshwari Ardad, 25-year-old elder sister of the patient. Both of the informants were reliable and concerned and gave adequate information. The total duration of illness was 1.5 years. The reason for current admission of the patient was increased suicidal ideation and attempts since the past 1 month, causing disturbance to the family. The chief complaints, according to the patient, which aggravated since the past 1 month, were sadness of mood, loss of interest, reduced appetite, sleep disturbances, constant worrying thoughts about future, and suicidal thoughts. And according to the informants, were increased alcohol consumption, reduced communication, irritability, staying aloof, and multiple suicide attempts in the past 1 month. The predisposing factors being family history of a depressive disorder, precipitating factor being alcohol abuse, and the perpetuating factors being a depressive episode and alcohol abuse. So the patient was apparently all right until 1.5 years ago when he was appearing for his second year semester exam. He appeared but couldn't do well according to him in the first three papers, and gradually started experiencing sadness of mood throughout the day, which was persistent and pervasive, associated with loss of interest, inability to focus while studying, which led to irrational thoughts and worries regarding failing in the exam, leading to sleep disturbances, delayed onset, and intermittent awakening for around 2 to 3 days, resulting in failure to appear for his last paper. The above symptoms lasted for around 4 to 5 days, and gradually, due to increased frustration, he became irritable over trivial issues and ended up having arguments with his friends due to the same. That day, on advice of his friends, he consumed alcohol for the first time. He consumed around 2 bottles of beer when he was alone in his room and felt relieved. The above symptoms and daily alcohol consumption continued for a month, and the patient also started having fleeting suicidal thoughts, which would last for 5 to 10 minutes, 2 to 3 times a day. And in the same month, one day, when his result was declared and he failed in two other subjects in an intoxicated state, he planned to attempt suicide, precipitated by fleeting suicidal thoughts since 1 week. He went on a railway track without communicating about it to anyone, but claims that on reaching the railway track became fearful and aborted the attempt by self and returned to his hostel. For the next 4 to 5 months, the above symptoms persisted, and he continued consuming alcohol, around 180 to 240 ml of different types of alcohol daily, alone or along with friends throughout the day, and stopped attending college and isolated himself. After 6 months of his first attempt, he tried to hang himself in his hostel room when he was alone in the room, was not under influence of any substance, had suicidal thoughts whenever he was alone in the room, and had procured a rope a week before the attempt and tied it to the fan and was contemplating about the same when he received a phone call from his friend whom he communicated about the same and was talked out of it by his friend. And the patient claims he realized what he was doing was wrong and aborted the attempt, felt guilty after the same as he realized his responsibility towards his family. But gradually he started experiencing nausea and reduced his alcohol consumption within the next 1 month and started consuming only occasionally once a week whenever he would feel restless to relieve his frustration. After reducing his alcohol consumption, he started feeling restless and anxious the entire time, started feeling helpless, started making plans for killing himself, and once he was alone in his hostel room, under influence of alcohol, under impulsivity, even took a bottle of phenol which was lying in his room, but aborted the attempt claiming to be afraid. The above symptoms and alcohol persisted for the next 3 to 4 months, leading to absenteeism from college, along with sadness of mood, which was persistent and pervasive, persistent worries regarding academic impairment, sleep disturbances, which were delayed in onset, along with intermittent awakening, reduced energy and enthusiasm in the morning, reduced appetite, irritability, loss of interest in all previously pleasurable activities, suicidal thoughts throughout the day, which led him to visit a psychiatrist, and he was started on medications. After consultation, within 1.5 months, he reported around 30 to 40% better with significantly reduced irritability and also stopped consuming alcohol. The rest of the symptoms gradually improved within the next 5 to 6 months on regular medication. The patient reported around 80 to 90% better for a period of 10 to 20 days, due to which he became non-compliant to medications. After stopping medications for a month, he had relapse of symptoms of sadness of mood, suicidal thoughts, also started complaining of intense craving for alcohol, and started consuming alcohol again, occasionally around 200 ml of whiskey or 2 to 3 bottles of beer in the evening, once every 10 to 15 days with friends or alone. Within 1 month of non-compliance, the patient again started complaining of aggravation of symptoms, and since the past 3 to 4 months, made suicidal plans multiple times but did not visit a psychiatrist in spite of it. The patient returned home and stopped attending college during this period. He started complaining of fluctuating suicidal thoughts occurring throughout the day, every day since the past 1 month. He was abstinent from alcohol for a duration of 3 to 4 months. Until 1 month back, when he consumed alcohol along with his friends, and on returning home after being taunted about the same by his parents, tried to hang himself at his home under the influence of alcohol with no active precautions taken to avoid discovery, as everybody was present at home, and was stopped by the family. After which he started consuming alcohol occasionally whenever he would go out with his friends until 20 days back, when, after having interpersonal issues with parents regarding his poor academics and alcohol consumption, he went with his friends to consume alcohol and, under influence, had expressed his intent to die by consuming tablets. And on returning home, he ended up consuming 25 tablets of clonazepam, which he was earlier prescribed by the psychiatrist, and fell unconscious and was followed by his friends till his house and was taken to the hospital by them. He claims that he regrets the failure of his attempt. There was a history of self-harm 14 months ago when the patient was consuming alcohol alone in the room and suddenly felt restless and felt the urge to harm himself. After consuming alcohol, he broke the beer bottle and made a superficial vertical cut of around 2 to 3 centimeters on his left forearm. There is history of self-harm 10 days ago when, in order to relieve his anxiety, he made multiple superficial cuts on the left forearm using a broken beer bottle when he was not under influence of any substance and reported feeling better after that. There is also history of occasional consumption of cannabis 2 to 3 times in the past, along with friends, smoked in the form of joints. There is no history of crime under the influence of alcohol. There was no history of any inhalational or IV drug abuse or abuse of any other psychoactive substance. No history of any fear of specific object, anxiousness, palpitation, or feeling of any impending doom. No history of discrete periods of excessive talk, expansive mood, excess expenditure, over decorativeness. No history of repetitive, intrusive thoughts or acts. No history of suspiciousness, beliefs or thoughts being controlled by others or being heard aloud or maintaining abnormal postures for long. No history of fever, seizures, head injury, focal weakness, or double vision or headache. In past history, there is no history of any mental illnesses in the past. There is no history of tuberculosis, diabetes, or hypertension, or any other medical or surgical illness in the past. Family history: the patient was earlier staying at the hostel along with a roommate, shifted to his home around 14 months back, stays in a nuclear family along with his parents. The father, Digambar, that is a 50-year-old male, educated till B.Ed, working as a school teacher for 5th and 6th standard students in a local Marathi medium school, and shares a close relation with the patient. Mother, Mukta Ardad, 45-year-old female, educated till B.Ed, also works as a school teacher for the 8th to 10th standard students in a local Marathi medium school, has been suffering from depression and is on medication for the same since past 2 years. Elder sister Jnaneshwari Ardad, a 25-year-old female currently preparing for her UPSC exams, shifted to Delhi for the same around 8 months back. There is no history of any suicide or absconding or epilepsy in the family. History of alcohol consumption in both maternal uncles since 10 to 15 years. In perinatal history, the patient was born of a normal delivery at full term at a hospital, cried immediately after birth. There was no history of fever, rash, or any pregnancy complications. No NICU care was needed. No history of any seizures or complications. No history of any delayed developmental milestones. Educational history: the patient was put to school at the age of 6 years, completed his 12th standard and secured 73%, was average in studies with no complaints from school according to the parents, currently was pursuing the hotel management course in MGM, a third year student, and has attended college irregularly since his second year. In sex and marital history, the patient is single, unmarried. There is no history of any relationship or affair. Started masturbating 2.5 years ago, once or twice a month. Also watches porn along with it sometimes. Pre-morbid personality. Before illness, the patient was a social person, had a friend circle of around 8 to 10 friends in college, used to interact well with everybody, liked to study, would also participate in social events happily. But also did not like to share his problems with friends, was overtly sensitive to stressors like fights, exams, and would become fearful while facing adverse situations in life. In forensic history, there was no history of any conflict with law, no history of any FIR or impending court case against the patient. In physical examination, the patient was a young, averagely built male of good nutrition, febrile, vitally stable. There was no pallor, icterus, clubbing, cyanosis, pedal edema, or lymphadenopathy. In systemic examination, in cardiovascular examination, the heart sounds were normally heard. There was no murmur. In respiratory system examination, bilateral vesicular sounds were heard. There were no creps or bronchi. In poor abdominal examination, the abdomen was soft, non-tender, no organomegaly was noted. In CNS examination, the patient was conscious, cooperative, no cranial nerve palsy was detected, no sensory motor deficit. Plantars were bilateral flexors and deep tendon reflexes were normal. On mental status examination on the day of admission, the patient was averagely built young male, well kempt and groomed, dressed appropriately with good self-care, was making good eye contact and rapport was established, had appropriate behavior, psychomotor activity was normal, The speech was fluent, non-spontaneous, with intact reading, writing, and comprehension. The tone was normal, fluctuations were present, volume was reduced, productivity was normal. It was goal-directed speech. The reaction time was increased. Mood was sad, affect was sad, stable, reactive, congruent, and appropriate. The possession of thought was of self. There was no formal thought disorder. The content of thought being constant worries regarding future, feeling of loneliness, and fleeting suicidal thoughts. He denied any perceptual disturbances. Abstract thinking was intact. Orientation, the patient was oriented to time, place, and person. Attention and concentration was arousable and well sustained. Memory, registration, and recall was 3 by 3, and remote and recent memory were intact. Intelligence and fund of knowledge was adequate. Judgment, personal judgment was not intact, but social and test judgment were intact. Insight was 3 by 5. And mental status examination on the day of discharge, the patient was averagely built, middle-aged male, well-kept, groomed, and dressed appropriately, making good eye contact and rapport was established easily. Behavior was appropriate and psychomotor activities were normal. Speech was audible, normal with normal rate, tone, and volume. Productivity was normal. Goal-directed speech was present. Reaction time was normal. Patient had euthymic mood and affect, was euthymic, stable, reactive, congruent, and appropriate. He denied any perceptual disturbances. There was no formal thought disorder. Abstract thinking was intact, was oriented to time, place, and person. Attention and concentration was easily arousable and well sustained. Memory was intact. Intelligence and fund of knowledge was adequate. Judgment, personal, social, and test judgment were intact, and insight was 4 by 5. The course during hospitalization, the patient was investigated. The labs showed no significant abnormality. The patient was started on tablet escitalopram 10 mg at night and tablet clonazepam 0.5 mg twice a day. Pre-anesthetic evaluation was done and the patient was posted for ECT. Patient reported feeling better with reduced frequency and intensity of suicidal ideations after 2 cycles of ECT. And over the course of 10 days after receiving 4 cycles of ECT, the patient reported significant improvement in mood symptoms, reduced irritability, and denied any suicidal thoughts. The diagnostic formulation, the patient Madhav Digambar Ardad, a 21-year-old unmarried male residing at Taluka Gevrai, Bid, came to the OPD with complaints of sadness of mood, constant worries, anhedonia, suicidal thoughts, and alcohol consumption, with multiple suicidal plans and attempts since 1.5 years, aggravated since 1 month, along with history of self-harm, with a family history of depression and alcohol abuse, and on mental status examination had sad mood and affect, reduced rate and volume of speech, with increased reaction time, hopelessness, helplessness with suicidal ideations in the thought content. So the diagnosis according to ICD-11, code 6A70.3 is single episode depressive disorder without psychotic symptoms with harmful pattern of use of alcohol with suicide attempt with personal history of self-harm. And according to DSM-5, 296.23, major depressive disorder, current episode severe. The differential diagnosis being adjustment disorder, depressive type, and substance-induced mood disorder. So I would like to admit the patient in the ward independently under MHCA section 86, indication being the risk of harm to self. Would like to investigate the patient, do the routine lab investigations like complete blood count, LFT, thyroid function tests, RFT, and serum electrolytes. Suicide risk assessment will be done using the Beck Suicide Intent Scale and CSSRS. In treatment, in pharmacological management, the short-term treatment, I will aim to alleviate anxiety and secure the patient and to control the suicidal ideations. I will start the patient on antidepressants, SSRIs like escitalopram at 10 mg per day with close monitoring of the patient, and benzodiazepines for reducing anxiety, agitation, and insomnia. ECT if there is no improvement on medications. In long-term pharmacological treatment, I would like to maintain the patient on antidepressants after the acute episode is over. Check the compliance to medications in regular follow-ups. Suicide risk assessment to be done in regular follow-ups. Watch for side effects and recurrence of episodes, and laboratory monitoring of LFT, CBC, weight gain, and BMI in follow-ups. And in non-pharmacological management, psychoeducation of the patient and family members, creating a suicide safety plan, teaching coping strategies to the patient, and cognitive behavioral therapy.
Thank you, Nalini. I would invite Dr. Parker ma'am and Srivastava sir to take over.
And to me, I am really scared, listening to this case. Just can you tell me how many total suicide attempt, Nalini?
Ma'am, there were two aborted attempts and one interrupted attempt and many plans actually.
No, no, I'm not interested in technicality
Okay.
of this, because this patient, generally, I mean, if you have you looked at his intentionality, lethality, and inimicability. Are you aware of these three factors? I think Shilpa would be aware of, because I used to ask all these three questions in any suicide case.
Yes,
Yes.
I cannot ever forget that because
Yes.
all my
So
residency
what was,
and
I mean,
later
there is
as a
so many
faculty.
attempts, and we probably need to be extremely serious about this patient, right? So what is intentionality in each attempt? What is the lethality? I mean, there is hanging, there is the 25 tablets consumption. I mean, all the attempts to me look as very serious. So in terms of you should know intentionality matters. And what is intentionality, Nalini?
Intent is the knowing whether the act could end up in
The outcome should be
outcome.
suicide.
Huh.
That is intentionality. How much patient wants the outcome of the attempt as a suicidality, number one. What is lethality? What was the lethality in his attempts? There are so many attempts. So what is the lethality?
The last attempt was lethal when he consumed 25 tablets of clonazepam.
But attempting to hang,
Uh, he did not actually go and hang himself. He had just done
yeah,
preparatory acts.
yeah. So as a psychiatrist, we should be little careful. The kind of attempts which he's trying are all serious. See, he fails, that's another issue. Okay. And what happens if these are multiple suicide attempts, self-harm attempts? What would you think about it? And then history of alcoholism. So what is the inimicality? That is the lifestyle that leads to suicide. It is he has alcohol. So how intense alcohol would make his suicide attempts? Alcohol is known as a chronic suicide by Carl Menninger.
Yes. Yes.
So, in the whole thing, while he's attempting, there is alcoholism also,
Yes.
which is alcoholism is a self-sabotaging, right? That's the reason why Carl Menninger calls it, and this is a very beautiful concept, chronic suicide. So, on the backdrop of chronic suicide, the patient who is trying to attempt suicide, I think his each attempt has to be considered as serious, right? I mean,
Yes, ma'am.
what DSM textbook says, it's a different thing. 1.5 years, and almost if you calculate aborted, attempted, almost there are 4 or 5, right?
Yes, ma'am.
4 or 5 attempt. So this is a serious business here, and that's the reason why one probably need to think about what risk factor you would consider in these patients.
Young age,
Yes,
alcohol abuse,
yes,
history of self-harm,
yes.
family history of psychiatric illness.
Hmm. In view of the suicide, I mean, if you know this patient, so we know all those common risk factor. But what are the risk factor you would be worried about?
Impulsivity,
Hmm. Alcoholism,
alcoholism.
and then you are diagnosing him as a MDD,
Yes,
right? So
yes, ma'am.
MDD and comorbid alcoholism, that makes the whole seriousness of this suicide is absolutely troublesome. But there is a third factor also, which is that would you like to assess his personality
Yes, ma'am.
in terms of the pathology? And that's the third factor. Remember, in suicide, as the comorbid factors keeps adding, the intensity and the outcome, as a suicide keeps increasing. Okay, I would add Ashish now, and I will come back to it.
Yeah, madam. You started very well. I'll take few pointers from you. Nalini, when you take a history of suicide as an emergency, psychiatric emergency, the most common psychiatric and most fatal psychiatric emergency, what are the risk factors usually you have listed? There are certain modifiable, there are certain non-modifiable. But in this patient or in all patients, certain other things very, very important when it is so many attempts, which is an area which you should have covered a little more. One of
Personal.
the personality is one thing. Second thing is there is family history of suicide should also come in, and psychosocial factors.
Yes.
Very important contextual factors which will be important for you even in management. What is his support? What is his perceived social support? What is available social support? There are different levels of social support also. So that you should learn. In personality, what are the things that you want to look at? In personality factors, what things that you look at in a patient with suicidal behaviors or attempts or plans?
Are there any borderline personality traits or
Okay, the personality traits, whatever. Okay, then only personality traits,
no, the coping strategies used by the patient?
correct. So how does he usually cope any stressful situations? Okay,
Hmm.
coping strategies, whatever. What is his emotional literacy, emotional needs of a patient? When you assess that, whether we will be able to provide, whether they are realistic or not, that assessment goes further on. Okay, and whether he really means when he deals with any stressful or problematic situation, what is his problem solving skills? Also,
Yes.
again, you're going to work on that in crisis management. So that are very, very important. So two areas. In intent, no, when Madam was saying suicidal intent is very important to look at in a patient, in a young male with multiple suicidal behaviors, attempts, interrupted or whatsoever. So what are the areas that in intent, what you look at?
In intent, I will look at the timing of the. In this patient, I had applied the Beck suicide intent scale. In which,
That's okay. Scale
ah,
will come, but intent is assessed both objectively and subjectively.
yes,
Correct. So what
yes,
does what does it mean to the patient consuming a bottle of phenol? Okay, or 25 milligrams, 25 tablets or 0.25 milligrams of clonazepam. What does patient mean? Patient may means believe it is very, very going to take away his life. It's a very dangerous method. We may not, we may say, okay, it was 1 milligram tablet, then it would have been very lethal.
yes,
Intent was harm and it was very lethal. So it is subjective and objective assessment because what is dangerous in actuality and for the patient is different. Simple attempt by patient maybe he may perceive as very dangerous attempt. Second thing, any preparatory behaviors, you understand in intent, there are certain behaviors, preparatory behaviors, rehearsal behaviors. So one should ask those details. Did this patient had any of them? Do you understand those factors? What are preparatory and rehearsal?
preparatory acts are. Did he write any note? Did he give away
Correct.
his belongings?
Good, very good. And okay. And what are rehearsal behaviors?
Rehearsal behaviors are planning the entire act.
Rehearsing it,
Yeah, rehearsing it.
which he in his mind he goes, I will go to that corner shop, I will buy the phenyl bottle from there, or I'll buy the rope from there, I'll get it this. How will I get it? Whether he will be able to hide it. So how much that will also show his intent, right?
Yes.
This patient of yours had, quite a few times been fearful, not able to attempt the thing, or has been superficial attempts, has been stopping himself at the ends of the behaviors. He, other than that tablet overdose, he never had a made a serious
Okay.
completed attempt. Correct? Right, kind of that. So, what do you think is working there? What do you feel that is a good factor for him, or is a very bad factor?
It is a good factor
Hmm. Yeah.
because unless
So
he has
there are certain good factors which also need to be elicited when you're racing them. What are they called? Protective factors.
Protective factor.
So when you elicit a suicidal behavior or assessment is done, clinical assessment, you should elicit protective behavior. Can you name some protective behaviors in general?
Good social support.
Good.
If there is good economic status, good problem solving
Employment.
skills,
Employment,
employment,
financially stable,
good
career
problem solving
stability. Yeah.
skills,
Good.
problem solving skills.
Very good. Yes. In general,
Hmm.
what other things? Let's say if this was a 28-year-old lady, what other protective factors would you think of?
Pregnancy, marriage,
Yes. Attachment to family, familial
attachment to family.
status. Is he staying alone or is staying, does he have a family which he looks upon for social support? Yes, under endocrinopathies, medical factors will become some important. Yeah. Yes, ma'am. Ma'am, you'll have to unmute yourself. Ma'am, you're
Ma'am,
muted.
unmute.
Very important question in this case. 1.5 years, and there are so many attempts, whatever, let us, because to me, after years of experience, I would tell every attempt seriously. See, whatever America teaches us aborted attempt, let us forget that. Suicide is an art and science for a psychiatrist. Okay, so taking into background into into a picture, I want to ask how, I mean, was he hesitant to take treatment after each attempt? What was happening after each attempt? Any idea? Was he with you or was he with a doctor? And what was happening? I mean, what happens when one attempt goes to the other goes to the third, and there is literature which says that one should be careful after the last attempt in a year, the repetition of the attempt is very common, basically. So this is a very important aspect. Have you thought about it, Nalini?
Yes, ma'am. The initially was hesitant to visit a psychiatrist, but
Hmm.
after around 5 to 6 months, he visited the psychiatrist for the first time,
Hmm.
and then again felt better, stopped medication, and isolated himself
Yeah.
because again he had increased thoughts.
Yeah, because there are a lot to be suicide. The literature in the whole world is bombarded in terms of the assessment. I would, for your patient, there is a one important aspect which I would say there is something called as a kindling effect. Kindling effect of each attempt. That means, the brain recollects that attempt, and every time when there is a ideation, which comes, that gets activated in the brain, right? So this is a very important when you have repeated suicide itself is a very important repeated suicidal behavior. It's a very important aspect, and we have to, take the treatment. We shouldn't just in the diagnostic formulation we from the theory we give it. Now this patient need to be handled on two things. One is a kindling effect, which probably you have to now keep that in the mind, because this patient will keep coming to you, and by chance he will miss his judgment and he will die of suicide. Yeah, mark my words, because this is what happens in most of the patient. That's the reason why we should be very careful. And there is something else which is we probably you need to be careful about, and that is treatment hesitancy. Okay, most of my patients, Shilpa remembers, I used to see it, repeatedly on Tuesday afternoon in my suicide clinic, keep waiting for the patient. Most of these patients generally they don't come because there are many issues. The issues like stigma, the issues like feeling ashamed of suicide, the issues like not feeling serious. So there are many issues, basically, and feeling frustrated about the reasons. So we have to really identify that. Okay, but don't forget this word kindling effect. If patient keeps coming with each attempt, his seriousness, his intentionality, his lethality is going to increase. And unfortunately, what I want to say, I don't like to say, that is, he will die one day with suicide. The another thing which popped up in the thing is his alcohol. It makes him doubly risky. Okay, because tell me, how much alcohol increases the risk of the suicide? In comparison to those who do not have alcoholism. A very
Around
serious business, yes?
2 to 3 times increased risk of.
No, two, three times is a very mild. The from Europe to America, the risk can increase. Even people have finished studies say the risk can increase up to 40 times more. Alcohol is actually the important risk factor. I won't be worried 2 3 times, but it is lot, because see, alcohol increases your impulsivity. Alcohol increases your aggression. Alcohol increases the control on your thought process. So everything, because it causes disinhibition. And the person who is so impulsive, that disinhibition by alcohol is risky phenomena. Okay, so that is the one thing which you have a lot to work on this patient. I won't leave this patient easily. I mean, I would see that he comes, but the treatment hesitancy, what are the issues which you would like to evaluate in terms of treatment hesitancy? You really need to manage that. See, when we say CBT, even if you know it's not easy, because they're hesitant to come back to you. So how do you manage treatment hesitancy? A very important red flag in suicide management. A very important to all of the student. Remember that the suicide patient and with this kind of patient is challenge. So we have to look at alcohol, we have to assess his personality, and we have to look at the range of the issues. So right from the stigma to what are the barriers to care? What makes him not come to your care? Have you thought about it, or have you asked why he doesn't do the follow up? And that needs to be managed by you.
Yes.
Otherwise, this patient would die while you are under care, and you will end up feeling guilty about it. So this treatment hesitancy is a universal problem, whether it is in India or America, and that needs to be managed by a psychiatrist. So what would you do for that?
Psychoeducate the patient and the family
Yes,
members.
yes. Psychoeducate means what would you exactly do? Let us get into it.
Explain the family members that the patient is suffering from an illness and is at risk of committing suicide again or attempting suicide again.
Hmm.
And
But but
so
he does it when he's alone, when he is in hostel, when he's alone, when he's not with the family. So it will be difficult for the family. So what you should do with the patient? Yes, of course, you have to psychoeducate the family. You have to tell them the risk, and very clearly. Otherwise, patient would blame, the relatives would blame you that you didn't tell us and he died while he was under your treatment. So you have to tell that the risk of the suicide is going to be high in this patient, right? That is very important, even medico legally. But what would you do for the treatment hesitancy?
I would educate the patient about his illness and tell him that
Yes. The illness, his alcohol, you have to tell him about all the risk factor, and tell him that is the reason why he becomes vulnerable. And then, of course, you have to deal with his coping styles and work on his resilience. This patient, because something which was missing is this aspect. This patient's resilience probably is really less. Okay, so eventually you have to work on the coping styles and resilience and hesitancy management, and of course the pharmacological treatment, right? Which drugs will be helpful in? You said SSRI, right?
yes,
What else you would think?
lithium can also be.
Yes. Lithium. which is the best drug in psychiatry which can be called as anti-suicidal? Lithium, of course, is a good drug along with antidepressant, but you can't call lithium as anti-suicidal. So, which is that drug which is really, you can rely on that drug? I am asking in general, which is that drug which is known as anti-suicidal in psychiatry?
I'm not sure. Is it clozapine?
Clozapine?
Clozapine.
Yes, it is an anti-suicidal drug, which is very recognized, in the multiple drug control trials. It is recognized as, but here you have to go probably add lithium in this case because you have their alcohol, you have repeated, you have impulsivity. You have not mentioned about aggression, so I am not sure about the aggression. His personality, need to be evaluated a lot, and you have to always work on the treatment hesitancy, which is a very important concept in the area of the suicide all over the world. Because if patients don't come, you won't be able to help him. So, and why he doesn't come is an important issue, and that required to be worked upon. And remember, engage him, engage him, and to take the responsibility of his behavior, which is very important. I mean, it is a collaborative, aspect by therapist and the patient going together. So I think I will stop here. It is a lot. I can go for next 8 days on this. Right.
Yeah. Nalini,
Yes,
so
sir.
what ma'am is basically saying for this case, she has brought out a lot of pointers that we need to be prepared with to deal with such a case. But how would you sum it when you are interviewing the current episode of self-harm, no? Yeah, Bhavesh wants to say something.
Dr.
Dr.
Bhavesh,
Bhavesh,
sir, Nakhrawala sir. Sorry, please unmute.
So, Dr. Nalini, you
Yes.
have presented very nicely. But first thing is, you should not uh, disclose the identity of the patient while
yeah,
presenting the case.
Bhavesh, I thought I will conclude with that. Okay.
Huh? So that should not happen. Then, what is the severity of the MDD? You have said is a severity. So you should have apply some should have applied some scales. Have you applied?
No, sir, I did not apply MD.
So that's necessary.
Yes.
That mild, moderate, severe. What type of the MDD is there?
Clinically,
And
because this is a very important word Bhavesh is asking. Maybe
hmm,
you don't need the scale also. Clinically, what do you think?
Clinically, it was severe. He had a low mood, loss of interest, fatigability.
The minute suicide plan or anything increases, the depression automatically become a very serious issue. Okay.
hmm. And I would like to talk about the cognitive distortions, because in depressed patients and with so many suicide attempts, there may be so many cognitive distortions you have to identify, and that is the personality factor that uh, uh, our both the experts have talked about. Which are the cognitive distortions, which can be found in patient with MDD?
Overgeneralization,
Hmm.
all or none thinking.
Yeah.
Mm.
So you should ask in each and every patient of the MDD, because uh, it you have plan you have mentioned in your treatment that psychotherapy or CBT is one of the aspect. So CBT, it all depends on the cognitive distortions. Okay,
Yeah.
that's all from my
Then there are
side.
many cognitive distortions like tunnel vision, minimization,
Yeah,
generalization.
there.
So many things can be present in these patients if there is severity of it. So you can sum it up. See, all history of past episodes and all you've taken. The current episode history, when you go to take current episode of self-harm, He presented with self-harm. Okay. When you take it in the position of what happened before, what happened during, and what happened after. So before is your precipitant, and you are given those some of the factors in there. What precautions you take, what precautions you did not take, all those things. And during also you have intent and lethality, all that. But after, what questions you would ask? What we really forget. I don't think it's come in your history also. Did you ask him what did he think after the attempt?
Yes.
Immediately after the attempt, what were his thoughts? And what areas would you like to, what would you ask him there? As a postgraduate student? Yeah,
Did he feel guilty about the failure of his
good.
attempt?
Yes. Guilt. Okay. Did he feel guilty about the failure
Failure
or
also,
the other way around?
or did
Did
he
he
feel
regret it?
guilty for attempting?
Regret
Regret.
attempting it. Yes, that is more important. Yes. What else? Now,
He,
since the attempt is made, does it does he feel relieved? Or is there any it's a relief symptom? Does he feel his tension is reduced? Because obviously doctors have come in, help has come in, something has built up. What is his response? What are his mood symptoms now? What is his relief factors now? What else? Would you like to repeat it? What do you think is the possibility that it may happen again with you? Okay, very empathetically, you have to ask these questions. What else? As madam was saying, if this happens, what do you think you will do to feel different? Okay. Would you like to accept any treatment for the same? Madam was saying hesitancy treatment. These are the questions which have to be asked per se related to the event when somebody presents to. This all the areas we too tend to forget. Mhm. So what according to you is his level of whatever we say intentionality or your suicidal risk? Clinically, we grade them into what categories?
low, medium, and high risk.
Okay, mild, moderate, severe, or low, medium, high risk. So what do you think in this patient and why is it based on? What are the indicators that you say? It is mild, moderate, or severe in this patient?
It is severe according to me because he had intent, he had risk factors.
Hmm.
There were very few protective factors.
Very few we don't know
Hmm.
because all his psychosocial history we have not evaluated his consents. They have not evaluated. He was in a hostel, but he has his friends who always been there with him. Okay, so moderate to severe attempt, definitely moderate severe. And so what will be indication? What will be your targets for intervention in this patient? You have said it in your
Yeah.
management. Can you put it into areas for target? Where you will target his interventions. One is you have treated. You have started with treatment with SRIs. You would like to give ECTs, hospitalize it. So treatment of the mood symptoms of the mental illness that he's going through,
Yes.
psychological illness. What else?
And behavioral interventions. Other than
Okay,
that.
behavioral interventions also for the same thing.
Yes.
Correct. What else? He has had 5, 6, 7, I don't know, many
Exactly.
suicidal behaviors and attempts. So what
It,
would you
it
look
really will
more?
make me sleepless,
Yeah,
even at
it is
this
very
juncture of
serious.
my life.
If we get at night on a night on call, if I get as a consultant, I'll be really after my residents to,
Yes,
you know,
5 or 6 symptom suicidal profile. It is really it is a shaking kind of thing.
mm. So what
And with
other areas of
alcohol.
intervention that you feel? You're not going to deal with
Alcohol
only
abuse.
his mood, no, his depression
Alcohol
will take
abuse.
time, 15 days. Let's see, ECT is also a week, 10 days. He'll improve. Definitive thing, you will control his mood. Would you not like to? His
Alcohol
mood will
abuse.
again. He went, see ECTs or he stopped his treatment. ECT effect also lasts for some time. You discharge, he goes back home, he has his energy levels back, mood goes down, he shoots another attempt. Okay. So what would you intervene? So another target of you should have no intervention target.
The compliance of
His
the patient.
yes, all to treatment. His adaptive behaviors, his coping strategies, all things have to be worked up other than that suicidal behavior and mood symptoms. that his personality traits all needs evaluation and workup on that area. Again, his psychosocial interventions are very, very important in the patient. You'll not be able to, you'll admit the patient, but you'll not be able to discharge this patient till you work on those areas. Hmm? Whom he will go with? Again, you're going to send him to the hostel. A practical problem. So until you deal with those areas, means evaluate and deal with them, you will be with a question mark at the end of it. Okay, the father has come, somehow father will sign and take him. So the responsibility is of the father. It doesn't work. Nalini, in long run, we will not know only our patients whom we have lost and who are there with us or no. Okay. In the community, because I say the follow-up rate, stigma, and everything, there's so many barriers. Okay. So those areas are very, very important. Psychosocial intervention, you will involve your other faculties of psychosocial work and your psychologist to do that. Okay.
Yeah.
I hope you have those people working with you.
Yeah, I have one question. Every time he tried, he attempted or whatever, what was his emotion during that time? Can you tell that, Nalini? Have you asked? So it is a
Very
huge
important.
thing. So what was that emotion which, pushed him at the peak? Because that is a very important issue in the management. The emotional management skills will matter immediately, and he's going to be alone.
He felt isolated and helpless every time.
Hmm. What is, see, initially they used to say hopelessness along with depression. Nowadays, what do they see? Instead of hopelessness is also there. See, if there is a feeling desperate, if that is the emotion, you really need to take care of that, and you have to really teach that emotional management, which is a very important. Feeling desperate, because most of my medical students I lost on that. No, it is a challenge. I think all those who are attending, my earnest request, take suicide very seriously. Whatever you do, it's not just your knowledge that will matter. Your skill and your passion to treat them will matter a lot. And saving one patient will give you immense pleasure. Remember that. So all of you keep doing it and keep, improving your skills. Suicide is challenge, even for the gold medalist, expert, whatever. And every time the color is different. So I think every time I learn from my patient. Today also I learned from my tribal patients. So the knowledge matters, but the skill and the passion will matter. I think Ashish will agree. Suicide management is a passionate issue for the psychiatrist. Very
Man, it's a
passionate.
passionate and it's always never easy thing to
Never
do.
easy. Never easy.
I
Yeah.
when I was doing my project and thesis on suicides, completed suicides, so very, very painful psychological autopsy studies. So, Nalini, coming back to you, what do you think are barriers for detection and eliciting suicidal ideas or plans in any population or in your young, especially in young patients?
Guarded attitude, social stigma, that is why they don't share.
Correct. Very good. But also, the young people do not come out easily. Expressing about mental illness or suicidality is also a sign of weakness. And any phase they are feeling very weak. So they do not come out. So unless you give them a very calm, supportive, empathetic environment, they won't come out. What else? Societal attitudes about suicide.
It is social stigma, according to the society.
Stigma is one thing. Stigma is one thing. What else?
Many cultures don't support suicide.
I didn't get you.
I mean,
Each patient will have his own perception about, and his society, the immediate society will have its perception about suicide or self-harm behavior. They're called myths about suicide. Okay, you should be aware of them. You should elicit them. One another protective factor was religion. You should see whether what are these religious attachments, religious belief systems. That is another protective factor in many. So myths about suicide in him, his family, his immediate environment is very, very important to elicit. Suicide once happens, it never happens again in life. Those kind of statements, you will hear them again. So those kind of things you should elicit more. You said some scale you'll use. Which scale you'll use?
The Beck suicide intent scale.
Okay.
Mm.
You know how many item scale it is? Have you ever done it?
Yes,
Yeah. How many item scale and how many sections it has?
it is 3 sections
Very
and
good.
21 item scale it is.
Yeah. 19 or 21 item scale. And the other scale you mentioned is Columbia.
Hmm.
Decided. So it has 18 items. It is
Yes,
again 3 to 4, I think 4 sections.
4 sections.
Which scale is better?
Columbia.
Why you say that?
It is considered more
What are the
sensitive.
advantage of BSI over CSSR
In Beck
or
suicide,
disadvantage?
Columbia can be applied to any person, even if to assess the risk of suicide. But in for applying Beck's, the patient needs to have attempted or have the intent to attempt.
Yeah. So BSI is applied to a person who has already some
Ready.
risk of self-harm, while CSI can be given across psychological disorders or patients. Okay, what else?
CSSRS is a interview questionnaire, whereas Beck's is self-report. Beck's
No,
can
Bex can be both. So
Beck's
that's an
can be both.
advantage of BSI. CSI is interview attempt.
Mhm.
But you've seen the questions, if you have really administered both of them, you've seen the questions. The questions on BSI are much more easier and objective
Yes.
to ask. So mental health professionals, it's easier, faster to do it. So that's an advantage of BSI. CSSR are very complicated. Means they have some nominal data also. Means
Yes.
the options are of some questions are nominal in feature. So there you yes no you get into, which requires a lot of training. CSSR. Second thing, the advantage of CSR is that it is available
Free.
free every land, every country, many languages. While BSI is less accessible.
Yes.
Okay, you have to have some kind of you have to buy it and you have to purchase and those kind of things. And it's not available in as many languages as CSR. So these are the things that you should worry about. But practice both, and I means from my little experience, I would say that BSI gives you a better result. And there are many more skills, but these are the two instruments that are. Is any instrument foolproof? Will say that okay, is any instrument or any assessment says that patient will commit suicide or will not commit suicide?
No.
So what do you do if there is nothing sure? How do you next step is, or how do you take care of yourself and the patient? What is very important there?
Treat every patient as if
That is our ethics, no? Hippocrates oath, treat every patient, do no harm. Hmm? What you will take care in patient with self-harm behaviors? What care for yourself, as I said, and the patient?
have a
Very
non
important to learn it. Huh?
have a non-judgmental attitude.
For every patient you should have. No, why these patients? I think in every social interaction, not with patients, any interaction, you should have non-judgmental attitude. Very, very important is area of documentation. Hmm? So what all you document? It's very important to learn. Your third year,
Yes.
only soon you will be senior resident or crossing the line on the other side, no? Where you'll be sitting and teaching people. So if documentation, what are the points in documentation that you will remember when it comes to suicide or self-harm behaviors? You all do it regularly?
In the yes,
The
documentation.
documentation.
Yes.
Yeah. So what all things you document? Is it possible to document everything and anything?
Mm, the informant details, the patient details, the
Correct.
findings, like
Presenting complaints should
presenting complaint.
always be there, which is the act now should be in detail. Okay, that is what, if something happens tomorrow, the investigation agencies will come and ask you the first thing. Who came, what he did? Can you describe what he came with? Okay. Yes, next.
Then where he did it.
Okay. Quickly write your risk factors, protective factors, warning signs, acute stress symptoms, and mental illness details. What else?
The
Hmm.
vitals also are documented.
Okay, that is okay. Each and every member that presented with the patient has to be documented details. Okay. What are the treatment options did you give him? And what is the treatment option that he has taken? Right? Today in the world of MHCA, it's easy as well as very tricky. So NR takes the call, but you're also calling him as having capacity.
Yes.
So you need to justify tomorrow why and why, which are there are certain assumptive thinking that work here. Okay. And what is the safety plan or contact plan, whom he can contact, what he can do if he feels really suicidal again, and whom, where, numbers, all those things have to be in your documentation. You are accessible on what number, means your official
Yes.
institute's number. If you are in prior practice, then your personal details that has to be entered. And this should be present with the patient. This has been given. This has to be documented. Sometimes they leave. So you have felt this patient has moderate to severe suicidal risk. Still he says, I'm going. What do? You cannot forcibly admit this patient. This has capacity.
Yes.
So document his capacity. We have a capacity form. Okay. Obviously, you'll take undertaking from him, relatives, whatever. So, but tomorrow when it comes, you will have these all documentations ready. What few traps you will not get into yourself? What's it? I think we'll try to end in 5 minutes. Just 5 minutes, Aranda. Not more than that from my side. What common traps we put ourselves into when such a patient comes? We get scared and we put ourselves into those traps. We are treating psychiatrists or mental health professionals there, no?
Yes.
What happens usually, we tend to start taking responsibility of the patient, which is not our area. Okay, deal with the patient the best, effective, empathetic, whatever way. But we should never assume any responsibility of the patient. We should be very careful. We provide him all help, effort, time, but no, we cannot take responsibility of this patient or any other patient. For that, you should have a social support system for the patient. Okay, so as because you are not dealing going to do with one patient, you will deal with them almost daily or twice weekly or weekly at least. Okay, so those traps you never allow. Means you should set boundaries also in such patients, because these patients are more so relatives. If the relatives have accompanied hostel, let's see this student hostel, the friends. When such a behavior happens, what they want to reach out. So there should be a particular reach out plan, not 24 hours, 365 days. You yourself allow the boundaries to be broken at any time. Okay. Then it will be pressure on you to always be available and deal with it. It's a pressure. Because if you don't deal, assume responsibility come, patient will die, what happens? Okay. So all these plans will be there. Otherwise, burnt out will come. And hopefully we should not have avoidance at the end. No. Such patient I should avoid. No. We got to help such patients. There is no way we should avoid. But unless we take care of these steps, we will not be comfortable dealing. Okay. And only you have any question for us?
Not. Sir, I just had a doubt. Like all of his were they suicide plans, or will we term them as aborted suicides?
He attempted, no? He broke the bottle, tried to cut superficially. He didn't go deep, no?
Those were the self-harm attempts, but all the attempts where he tied the rope to the fan but did not do
Yeah.
anything. So will
It's
it
an abortive attempt. Abortive attempt. He took that step. See, action was taken. It didn't remain at a plan level. It didn't remain at an idea level. Some action was taken, did not complete. That is why one important factor I feel, this is a very young male. You should importantly analyze his personality. He may have some kind of, by experience, some kind of EUP traits. So whether he's depressed, but whether is the depression leading to suicide, or depression is secondary to his maladjustment to surroundings, and that he's not finding a way out. Any other thing that I can help you?
No, sir. Thank you.
Anytime. Yeah.
Yes.
Thank you.
Another thing, we can prevent the suicide. That saying that what will happen to your children or your wife or your family if you commit suicide? That can such case question can be very helpful. That will uh, uh, that will put the patient in a when once he will think that if I will commit suicide, what will happen? And another thing is that whenever such thoughts come, whenever you feel so much depressed, I am there to help you. But
या मैं हूं ना.
मैं हूं ना, लेकिन ऐसा नहीं कि 24 घंटा आप मुझे रात को 12 बजे फोन करो या रात को 1 बजे फोन करो, बट पर्टिकुलर आवर्स कि भाई आप मुझे कभी भी फोन कर सकते हो, आप मेरा कांटेक्ट कर सकते हो, यू कैन, आई एम अवेलेबल and I will help you.
Yeah. What Bhavesh is saying, very important 2 points is like you should provide him some contact. It's not necessary you always. So he should have some kind of a plan. What to do? That's called a management plan or suicide plan management at discharge or when you're not admitting the patient. You have to have the numbers written in your documentation. Huh? You should contact this person this time or this hospital, these numbers, whatever is your available resources based on that. Second thing, what Bhavesh has said, obviously, is very important. That it's a very important protective factor. Being parenthood, having children, having family is a very important protective factor, which should be elicited. I would put rather reminding him is like in therapeutic context. What do you think? Provoking him to think. What do you think your family is behind? How would they take this jolt if this happens? Because obviously he knew he had a family. Still, he went on to commit it. So, therefore, provoking him to think will be more, cognitively enhancing. Sometimes direct question, doctor, मुझे पता है मेरी बीवी है ना, लेकिन फिर भी मैं मरना चाहता हूँ. So obviously he's crossed that boundary. So, sometimes it's that way you use your hint to provoke a patient to think and manage. It's important. But both the points what Bhavesh said are very, very important. I think Manik wants to say something.
Yes, sir.
And
Thank you. Yes, no. Thank you, Srivastav sir and Shubhangi madam, for very enriching discussion. We learn a lot from you. Dr. Nalini, I would like to state her that she is in fact doing her thesis on suicide itself. She is using both these scales, CSSR and BEX. So she and we all have gained a lot from this discussion. Thank you very much, sir and madam.
Thank you, Bhise sir. Thank you so much for encouraging and supporting Nalini and pushing her to present. And thank you so much, Nalini, for having volunteered to present the case. And it's not easy to face so many people, and it was almost like a viva. So it's a good. It was a good opportunity. You took it very good. It will help you in your preparation for your final exams. We all learned a lot. Thank you. Of course, I would like everybody to wait. Please don't go away. We have a 10-minute quiz following this, and Bhushan Maitre sir is there. He will conduct it. I would want to thank Parker madam and Srivastava sir. It's been a very enriching session, and I have also got to learn a lot. And whoever has attended today, all residents, I'm sure they have benefited a lot from it. And suicide is an important topic, not just for the practical purposes, but also as a theory. So I hope all the residents heard it properly, and if there are any queries, we are open. Please write it down in the chat box, but I think most of it we covered. in the discussion. It was a detailed discussion. Srivastava sir, you raised your hand. Would you like
I
to?
just want to say there is a very recent book, Suicide Indian Perspectives. I have it in front of me. I think Madam has been an editor for it, Parker Madam. All PGs should at least go through it. It gives you a good Indian perspective and overview. Then you can read much, much more. So it's a good book. It's available.
Thank you, sir. Anybody else would like to say anything before we move on to the quiz? Shilpa ma'am?
No, I just want to thank Dr. Parker and Dr. Ashish for chairing and making it a comprehensive suicide session and Dr. Nalini presented very well. Very good, Nalini. Very well taken. Maybe few points you missed, but that's what you learn. So I think by the time you appear for your exams, I think you'll be totally prepared. So I think it was a wonderful session, and from how to take and how sensitive to be about asking questions to figuring out cognitive distortion, CBT, and also how to not get trapped and take care of yourself in a patient of suicide. Everything was covered so well. So thank you, ma'am. Thank you, Dr. Ashish. Thank you, Nalini, and all those who attended and participated. Thank you. We'll move on to the quiz.
Yes, sir.
Dr.
So,
Bhushan.
yeah. So, quiz will be conducted by Dr. Bhushan Maitre, sir, who is a convener in our IPS West Zone quiz committee, and also is.
Sri Lakshmi wants to ask something.
Ma'am, just wanted to say thank you to Nalini and all PG students who are coming every time and presenting. It takes a lot of courage to be in front of experts, that too in front of a live audience. But without them, I don't think any of us could have any learning. So kudos to all the residents, and please do continue participating with this much enthusiasm. Thank you.
Thank you, ma'am. Thank you. So, over to Dr. Bhushan, sir.
Yeah. So we have 10 questions on emergencies in psychiatry. So I will ask Yogesh to start the quiz. Yogendra?
Yes, sir. Can you see it, sir?
Yeah. So a patient presents to emergency room with symptoms of catatonia, including mutism, posturing, and negativism. Which of the following interventions should be prioritized in the acute management of this condition? So you need to mark single best response. Next.
It can't be visualized. It went.
I can't mark it, Bhushan.
No, I could mark one, but after that it vanished.
I am also not being able to mark it.
No,
Yes.
madam.
Yogen,
Co-host cannot
Oh,
do the
okay.
poll.
Okay.
No, but I
Yogendra?
can't mark it only.
हाँ सर हम लोग co-host हैं इसलिए सर we
Acha. Okay.
Yeah.
Got it, sir.
It's already marked actually for us.
Okay. Sorry. Maybe we are not.
And the question
Permitted.
coming one below another. Because you have to scroll it.
Yeah.
Yes.
It cannot be visualized right now. Can you see it?
No.
On
Yeah,
your
we can
screen?
see it.
Yeah,
Yeah.
I can't see it either.
We are not co-hosts, but we still can't see the poll. So can you just check, please?
Yogendra?
Relaunch it.
Can I relaunch?
Yeah, please.
Yes, please.
How?
Is it visible to everyone?
Yeah, now it is. You can go ahead with the second one.
Yeah. So second one is, in the context of psychiatric emergency, which of the following assessment tools is specifically diagnosed to evaluate the severity of alcohol withdrawal symptoms? There are 4 scales. You need to mark the correct answer. The number 3, a patient presents with acute psychosis characterized by paranoid delusions, auditory hallucinations, and marked agitation. What is the most appropriate initial intervention in managing this psychiatric emergency? There are 4 options: rapid administration of typical antipsychotic medication, implementation of cognitive behavioral therapy technique, referral to outpatient psychiatric services for long-term management, admission to inpatient psychiatric unit for observation and stabilization. Question number 4. Which of the following medical condition is commonly associated with secondary mania and may present as a psychiatric emergency? Hypothyroidism, hypercalcemia, hypernatremia, and hypoglycemia. Next question. A patient presents to the emergency department with symptoms of serotonin syndrome, including hyperthermia, agitation, myoclonus, and diaphoresis. Which of the following medications, when co-administered with other antidepressants, is most likely responsible for this presentation? SSRI, TCA, MAO inhibitors, a typical antipsychotic. Question number 6. What is the primary goal of pharmacological management in patient experiencing acute benzodiazepine withdrawal? Treating underlying psychiatric symptoms, preventing the development of delirium tremens, reducing anxiety and agitation, reversing the effects of central nervous system depression. Next question is, which of the following statements regarding the management of acute agitation in pediatric patient is true? Pediatric patients should be restrained immediately to prevent harm to themselves and others. Benzodiazepines are the preferred first-line treatment for agitation in pediatric patients. Non-pharmacological interventions such as de-escalation techniques should be attempted first. Antipsychotic medications should be avoided due to their potential for causing extrapyramidal symptoms in children. Question number 8. In the context of psychiatric emergency, what does the term anomic suicide refers to? Question number 9. Which of the following medication is not commonly used in the treatment of delirium due to alcohol withdrawal and may also be beneficial in the management of acute agitation? The last question is, a patient presents to the emergency room with the symptoms of serotonin syndrome. Which of the following intervention is contraindicated in the acute management of this condition? Administration of ciprofloxacin, discontinuation of serotonergic medications, intravenous hydration with normal saline, and initiation of ECT.
Can we end the poll?
31 attendees, they are participating. 21 out of them have answered.
Yogen, I think 5-6 of us will be ours.
Yeah.
Yeah.
Can I end the poll?
Yeah. You can.
Yes, let us end the quiz.
You can give away the right answers to them. Yeah.
Yeah. So question number 1, the right answer is trial with benzodiazepines like lorazepam to elevate symptoms. So catatonic symptoms, they can be elevated by giving a trial of lorazepam. And the next option is ECT. Question number 2, the answer is Clinical Institute Withdrawal Assessment for Alcohol Scale revised. This scale is used to assess severity of alcohol withdrawal. Question number 3, for agitation, hallucination, and delusions in the initial intervention in managing this psychiatric emergency, it is rapid administration of typical antipsychotic medication. So we need to manage agitation even in the emergency room. So admission is the next step, but before that, we need to control the agitation. Question number 4, which of the following medical condition is commonly associated with secondary mania? The commonly associated condition is hypothyroidism, though even though hypercalcemia also can present with secondary mania symptoms, but hypothyroidism is very common and it can present with mania or even psychotic symptoms. Question number 5, a patient presents with serotonin syndrome and most likely medication when co-administered with other antidepressant which can cause this condition is MAO inhibitor. Question number 6, what is the primary goal of pharmacological management in patients experiencing acute benzodiazepine withdrawal? The primary goal should be always to prevent delirium tremens and withdrawal seizure. Reducing anxiety and agitation is also our goal, but the single best response would be preventing the development of delirium tremens. Question number 7, which of the following statements regarding the management of acute agitation in pediatric patient is true? And the correct answer is non-pharmacological interventions should be attempted first. Question number 8, in the context of psychiatric emergencies, what does the term anomic suicide refers to? So anomic suicide, it is resulting from social isolation and lack of belongingness. Question number 9, which of the following medication is not commonly used? So divalproate is not commonly used for management of delirium due to alcohol withdrawal. Lorazepam, oxazepam, these are benzodiazepines which are commonly used. Even diazepam is used and carbamazepine is also used to control agitation and withdrawal symptoms. Divalproate is not used. Question number 10, a patient presents to the emergency room with the symptoms of serotonin syndrome. Which of the following intervention is contraindicated? So we do not give ECT in this case. We should not initiate ECT. All other first 3 options, they are correct. They are plan of management of serotonin syndrome. So the result of this quiz will be announced in the next Tenacious Tuesday teaching session. And before concluding, we can announce the result of last Tenacious Tuesday quiz, which was held on clinical assessment of intelligence. And we have 4 students, 2 students who scored 9 out of 10. The Parth Akhani and Dr. Bansi Patel, they scored 9 out of 10. And Dr. Nidhish and Dr. Himadri, both of them, they scored 8 out of 10. So these are the winners of the last quiz on clinical assessment of intelligence. And result of this quiz will be announced in the next session. Thank you.
Thank you, sir. Thank you, everybody, for joining today. All students, all participants. Thank you very much, all seniors, experts, Dr. Shubhangi ma'am, Shrivastava sir. Thank you, Shilpa ma'am, Thank you, Lakdawala sir, for joining today. We had, sorry, hello.
No, go ahead.
Okay. No, I was just thanking everybody for joining today.